I did my topic on herpes, which was my infectious disease in pregnancy. For classification, there's 3 different classifications of HSV, also known as herpes simplex virus. Primary, which is a new infection of HSV, either 1 or 2 without antibodies to HSV 1 or 2. Non-primary is a new infection of either HSV 2 with antibodies of HSV 1. Recurrent, which is an outbreak or reactivation of HSV with the same type 1 or 2 of the antibodies that are already present. For prevalence of HSV, data was collected from 2007 to 2014 in a study from the United States Health and Nutrition Examination Survey. The prevalence of HSV-1 in pregnant women was 59.3 and HSV-2 was 21.1. In another study, it was found that HSV-1 was found in 63% of pregnancies and HSV-2 in 22%, with 13% for both HSV-1 and 2. Incidence of HSV-2 in the United States in 2018 was 572,000. Transmission is most common when the mother has a primary infection or a recent primary infection. It can occur when the fetus has a cut on the skin or exposure to mucous membranes on the fetus or prolonged rupture of membranes. The fetus can also be exposed in utero through the placenta. There's 2 different types of transmission: congenital herpes, which is an infection obtained from the placenta, and neonatal herpes, which is transmitted through the birthing canal. For fetal risks, these include spontaneous abortion, neurological damage, neonatal cataracts, stillbirth, skin ulcerations. 30% of fetuses with disseminated herpes infection will die. For the mother, if the mother has a current herpes infection near the genital area, then it would be recommended that they get a C-section to limit transmission to the fetus. In some cases, it may be recommended that they cover the area, though, with a dressing. So the subjective presentation for a primary outbreak, which is usually the worst outbreak that a patient would get, is going to be the genital or rectal sores. So they'll see some sort of a rash in that area. During the primary outbreak, the rash tends to be bilateral, larger, and it lasts longer than recurrent outbreaks. They may have 1 or more of the following: itching, pain, swelling, burning on urination, body aches, headache, fever, or they may be asymptomatic. In recurrent outbreaks, patients usually have lesions or a rash, and then they have less systemic symptoms. For the objective part of the visit, you typically will see genital lesions or ulcerations and enlarged tender inguinal lymph nodes. Differential diagnosis could be syphilis, but syphilis presents as painless ulcers, whereas HSV is painful. Folliculitis, patients would have red, painful bumps where their hair grows, or Beckett syndrome, which is can present as genital sores, but it's usually related to a issue with the blood vessels. For diagnostics, we can do serological testing, which is blood work for antibodies for HSV-1 and 2, IgG and IgM, with a viral culture, which can be a PCR or direct antibody fluorescence. The direct antibody fluorescence has very limited availability. Antibodies don't develop until 12 to 16 weeks after the infection. Should not be used to diagnose infection alone. Should swab the area as well. For a treatment plan for one of these patients, for a primary infection, we would recommend valacyclovir 1,000 milligrams BID for 7 to 14 days. For a recurrent infection, valacyclovir 500 milligrams BID for 3. For suppressive therapy for a known infection, it started at 36 weeks and continued until birth, and that's valacyclovir 500 milligrams BID. For non-pharmacological, if the patient's having lesions that are painful, you can try lidocaine on the area, making sure that the lesions are being kept clean and dry. Is also helpful to prevent any type of an infection. If the patient's having burning on urination, they can use sitz baths. Can also try Vaseline or a barrier cream when urinating so the urine doesn't touch the lesions. For education, making sure that the patient knows that they can still have a safe pregnancy and a safe vaginal birth, and it's done by taking suppressive therapy at 36 weeks until delivery. For follow-up, we recommend routine return OB visits and then careful examination of the vagina and rectum at time of delivery to determine if C-section is indicated, and at those later return OB visits like 36, 37, 30, and 39 week visits, For fetal well-being tests, there's no fetal well-being tests that need to be done related to HSV 1 or 2. Thanks.